Dr. Nagendra, the next step would be, let us say the stone is less than a centimeter. It is in a very favorable position in the pelvis or the veranda of the kidney, and its Hounsfield value is about 1,000. Not very hard, not very soft. What would be your advice for this patient?
So this kind of patient is easy to treat, and we have multiple non-invasive, non-surgical options for these kind of patients. One, this patient can have a stent placed and then go for something called as a ESWL, which is extracorporeal shockwave lithotripsy, wherein because the Hounsfield units are on the lower side, it is relatively a softer stone. It can break easily with a ESWL without undergoing any surgery and on a daycare basis. And if at all, we also have an option of doing an RIRS for this patient, which can directly place the flexible scope inside and lace it with a laser. Stone can be converted into powder. So these are the general options. We have.
So we can do stented extracorporeal shockwave lithotripsy as a daycare or OPD procedure. If the patient wants the entire stone removed in one sitting, we can consider retrograde intravenous surgery. Suppose the stone size is between 1 and 2 centimeters and the Hounsfield value is say 1300, is a hard stone like diamond. What would the options be for this patient, Dr. Suraj?
So here we are looking for a bigger size stone and also a hard stone. So in these cases, there are multiple options which a surgeon can employ. So this is not a suitable case for ESWL because the fragments which originate from these kidneys would stay back in the kidney and they would cause lot of problems later on, or probably increase in size later, giving rise to multiple stones. So the options in these cases are RIRS is one of the option, but the patient must be explained, or we explain the patient that it would require the RIRS to be done as a staged procedure. Because hard stones are difficult to lace and the duration of the procedure lasts longer than 45 minutes to 1 hour. This might increase the risk of infection in the patient, so we terminate the procedure at the end of 1 hour, keeping a safe timing, and we do it as a staged procedure of RIRS. The other option is which was a gold standard technique prior. So this is called as PCNL, that is percutaneous nephrolithotomy. This is associated with better clearance rate of the stone, but is associated with some amount of bleeding and pain. So this option is also available for the better clearance of the stone in a single sitting. So there is another procedure called as ECIRS, or endoscopic combined intrarenal surgery, where we combine the advantages of both, that is PCNL and RIRS, where PCNL is done in a supine position, and in the same position the RIRS also can be done by another surgeon in a similar setting, so that all the fragments can be tackled easily, which are approached from both the sides, so the fragments are completely removed and the stone clearance becomes better.
So Dr. Suraj is alluding to the fact that today we do the PCNL, or the percutaneous nephrolithotomy, in a supine sitting where the patient is facing the roof rather than facing downwards towards the OT table. This is a newer technique which allows access to the private parts and also allows the combined modality of PCNL and RIRS to be used in the same patient at the same time by two different operators.